Hello everyone, I hope you're all doing super well. Welcome back to Karan Academy. My name is Karan, and today we're going to be starting off our series on neurology by talking about how to approach headaches. Now, headaches are a very common presentation, and probably the most common presentation you would see in terms of the neurological system. I think what's important here is not to be overwhelmed by all the possible differentials, because there are a lot of them, but to have a good understanding of the investigations that are important, the types of primary headaches, and how we distinguish between them. So let's start with a case. So Emily is a 25-year-old patient who presents to your GP with a one-day history of a severe headache. Now, just based on this tiny bit of information you have, what are some questions you might be thinking to yourself? Well, ideally, you might have a list of certain differentials that might pop in your head. And at this point, you might be thinking of the characteristics of these different differentials and thinking, based on this person's demographic, the fact that she's had a one-day headache, what could it be? The fact that it's severe, right? So when it comes to headaches, a really good way I like to classify my differentials is this acronym called ER visit. And it's really, really useful specifically for headaches. So ER visit is an acronym that stands for E for extracranial, R for recurrent primary, V for vascular, I for infections, S for systemic, and then you also have idiopathic, and then your T's. So trauma, trigeminal neuralgia, as well as taking pain medications. And we'll talk about each one of these in a bit. So I've highlighted the ones in green are the ones that you are likely to encounter and might come up on your differential list slightly higher. A few red flags you should always consider include meningitis, malignancies, and yeah, that's pretty much it. And also always never forget the extracranial, because there might be something else going on in the region that might present like a headache, but is present with a headache, but it's not actually an intracranial cause. So extracranially, sinusitis, pharyngitis, any infection in the ear, nose, and throat can present with a headache. COVID as well. Then you have your recurrent primaries, and this is probably going to be the most likely cause in most middle-aged and young individuals. So the three primary headaches, and the reason we call them primary is because they don't have any underlying cause, right? With an infection with meningitis, sinusitis, we know that there is an infection of the meninges because of a bug that's causing the headache and the pain. With these, we don't really know. It's considered to be a mixed etiology of vascular factors, but again, not super well understood. So tension headaches, migraines, and cluster headaches. For these three, you should know them in and out. You should know how they present, what the pain is like, how they're different, how you treat them, and so forth. This will come up on your exam. We then have vascular causes like temporal arteritis, which is going to be almost unheard of in a younger demographic, almost exclusively in people aged above the age of 50. And a typical sign that's seen in temporal arteritis is tenderness tenderness of the sinuses. And that's because you have inflammation of the temporal arteries. Infections, again, big one, meningitis, encephalitis, and again, the extracranial infections we talked about. Systemic causes. So they might be dehydrated, they might have an underlying endocrine problem, something like DKA, or many acid-base disorders can present with a headache. The big one that you should always look out for is malignancy. Now, when I think malignancy, some things that would lead me down the malignant pathway when I'm thinking brain tumors. Firstly, is this a primary or is it a secondary? Has it originated in the brain, which is what most brain tumors are? Or is it a secondary that it's come from somewhere else? It's a metastasis, right? Things that would make me think malignancy, pain that's gone on for quite a while, at least a few weeks, pain that does not respond well to typical medications, any symptoms of intracranial compression, like papilledema, changes to vision, balance issues, any focal neurological findings. All that indicates that there might be something that's compressing on a part of the brain. And lastly, a pain that is present in the morning and wakes patients up. Now, as a rule of thumb in medicine, if you have any pain that is waking up a patient from sleep, that is going to be considered significant pain that should be investigated and treated quite aggressively. You then also have, obviously, trauma. trigeminal neuralgia, which can present as a post-herpetic neuralgia with herpes infections, and taking pain meds, interestingly, as well. So I'll talk about this in a second as to why it happens, but just know that taking pain meds over a long period of time can cause withdrawal headaches. Okay, so just based on those differentials, let's ask some questions. So extracranial stuff, ear, nose, throat. Remember, have they had a runny nose, a cough, a pain in the ears? Have they had a fever, any discomfort or itchiness? You might also check for any cervical lymphadenopathy. All that's important to do. Now, with your recurrent primaries, this is going to be your bread and butter again. So you need to ask about pattern of distribution. And I've color-coded what each one of them presents with. So tension headaches is usually described, your typical tension headache is seen in younger populations. It's described as a band-like pain around the head, as almost as if someone has a band around their head. That's pretty typical of what it is. It's mostly triggered by stress or sleep deprivation, as the name tension suggests, and often in university students. I'm sure some of you might have had one yourself. Migraines are, I guess, the most common debilitating ones, the ones you'd be seeing in hospital and in GPs, because these can be very painful. They usually start unilaterally, although can be bilateral, and they usually are in the temporal area, so over the temples. The frequency of migraines, it may range from a few times a week to months, and typically responds decently well to medications, but then depends from person to person. And some people may actually require some prophylactic medications. Additionally, some things that need to be considered: do they have an aura, which is an abnormal sensation with their vision, often with the migraine? People with migraines often also feel very sensitive to light, which is why our go-to advice is that they should be lying down in a dark room and just waiting till the pain subsides. They might have some altered sensations as well, which may be taste, and you can have somatic auras as well. An aura may often precede the migraine itself, and that's important to know from a treatment perspective. If they know that they are having this aura and they're gonna have their migraine soon, they might take a medication at that point in time. Now, cluster headaches are really, really bad. They are unilateral usually with eye involvement. When I say eye involvement, I mean it's not vision that's affected, but they have tearing of the eye, they have eye pain, red eyes, and they can have it over short periods of time. What I mean by that is they have, let's say, 5 or 6 over the course of, let's say, 2 days, and then it goes away for a while and then comes back again over short periods of time, which is why it's called a cluster headache, because it comes in clusters, right? The character of pain, again, tension is relatively constricting. Migraine is considered throbbing pain, and which is why we think of migraines as potentially having a vascular origin, a vascular contributing factor. And cluster headaches are severe, they are constant, and they have often associated with burning or piercing sensations. And that is with the retroorbital pain that they do have. Other associations, so stress, obviously a big one for tension headaches. We talked about auras and photophobia. It's always good to ask for triggers of migraine, because that's going to be a big part of your lifestyle intervention. Triggers include common triggers to ask for. Obviously, just asking the patient, do you have any triggers, might not be very useful. But if you can ask if it's made worse after, let's say, periods of sleep deprivation, too much coffee, stress, and surprisingly enough, chocolate and sex are also considered to be migraine triggers. For cluster headaches associated with watery red eyes that I talked about, alcohol is considered a trigger, and they may also have, present with a Horner syndrome, which is your meiosis, ptosis, and anhidrosis. A good one, because it's the one that you're going to be seeing the most of, that is a migraine. It's good to remember a good acronym: migraine present with pounding headaches. So P for pulsatile, 1-day duration, unilateral, often with nausea, and are quite debilitating. One other thing that you have to ask every single patient that comes in with a headache is ask yourself, do they have any signs of meningism? Now, meningism just means inflammation of the meninges. And that's going to be neck stiffness, And for that, you're going to ask them to do a chin to chest test. So they're going to be touching their chin to their chest and ask them if they have any pain or stiffness in the neck when they do that. The second thing is photophobia. Again, important to ask for. Now, it's important to realize that when I say meningism, I don't mean meningitis. Meningism purely means inflammation of the meninges. If this is because of an infective cause, that would be meningitis. However, there are non-infective causes of meningism. So the other big condition that you will hear a lot about that does cause or can present with meningism is a subarachnoid hemorrhage. And that is because because with the subarachnoid hemorrhage, you have bleeding in the subarachnoid space, right? Which is the part that's lining the meninges. So that the blood itself may irritate the meninges, causing meningism. So how do we treat a migraine? The first step is obviously long-term. We're going to try to identify triggers and ask them to avoid them. But as you can imagine, if you're in a room with a patient and they're presenting with a severe headache, telling them to improve their sleep habits or cut down on coffee is not going to be the most useful thing. You're going to want good analgesia and antiemetics, especially if they're nauseous. So ibuprofen and aspirin are considered relatively first line. And you can give metoclopramide or domperidone as an antiemetic. It's important to know that when we talk about medications, they should be taking this as sparsely as possible. A medication use over 20 times in a week is considered the upper level of what it should be and is associated with medication overuse headaches. Now, the reason this happens is not super well understood, but what happens with these patients is once they stop taking these medications, they then develop the headache again. And that's a bit different to their typical migraine. So they would obviously respond to that by, again, taking more medications, and that they slip into a vicious cycle of just taking more and more medications. You can also use some specific anti-migraine agents if the frequency and severity of their headaches is very debilitating. And the most common one used would be a triptan. They have a very good response, and they're often taken at the onset of the symptoms. Going back to our first principles, you know how we talked about auras that can often be preceding the headache. So if they notice an aura, that would be a perfect time to take a triptan. And the most commonly used one is sumatriptan. In terms of prophylaxis, if nothing else helps and we think we need to put them on a prophylactic medication, beta blockers, TCAs, and amitriptyline are considered relatively good agents. There is no specific preference, but we usually just try one for 6 to 8 weeks and then see if we get a good response. Next, let's talk about some hemorrhages. So the 4 different types of hemorrhages that you need to think about are your epidural or extradural, sorry, that should be extradural hemorrhage, your subdural, your subarachnoid, and your intraparenchymal ones. Each one of them are quite different in their presentation, and obviously how they come to be and how they present. So let's understand why they happen and then how we treat them. You're going to be getting a lot of CT scans, right? And it's something there's something that you have to understand genuinely to a decent level, I'd say. Obviously, you would not be expected to know the intricacies of scans. However, you should be able to identify what kind of hemorrhage it is based on the CT. This would be, I guess, my guide to understanding brain hemorrhages. So a few questions I would like you to ask yourself next time you see a CT brain. If you suspect a bleed, firstly, what is the shape of the bleed? Is the blood acute or chronic or actively bleeding? Does it enter the sulci, and sulci being the tiny grooves in the parenchyma? Is there a midline shift? And that's commonly seen by looking at the ventricles and seeing if they're shifted to one side or the other. And is there a skull fracture that you can see that might explain the bleeding, or any subcutaneous swelling, which commonly accompanies a skull fracture? So let's look at this image, right? What is the shape of the bleed? Now, this would be what we call a lentiform shaped hyperdensity. Now, what does this mean? And I know this might be slightly confusing. A lentiform just kind of means like this oval shape, right? The fact that it's a hyperdensity purely means that it appears more dense or appears whiter than the surrounding tissue. Is the blood acute, chronic, or actively bleeding? Now, that's a good question. How do we identify that? So we look at the color or the density of the bleed. If it is a bright white color, or it's whiter than the surrounding tissue, or it's hyperdense, that would be typically an acute bleed, versus darker hypodensities are associated with more so chronic bleeds. Is it homogeneous or spotty? And as you can see, it's relatively homogeneous, meaning that it appears to be the same throughout the area. Next, does it enter and does it fill the sulci? Well, I would say not really, because it seems to be separate to the parenchyma, right? It's not bleeding into this. As you can see, it's well demarcated. And is there a midline shift? Well, it does look like it, right? Because as you can see, this is the midline and everything seems to be pushed to this side. And what does that tell us? That tells us that there is something that's increasing the intracranial pressure. So there is increased ICP. Now, why is an increased ICP even important? Well, for one, as you can imagine, excessive pressures are not good. That's a general rule of thumb. They can cause focal neurological signs because you compress, obviously, this part of the brain. But the one big thing we really are worried about is something called a herniation. Now, what is a herniation? A herniation, basically, with increased amounts of pressure from the top of the brain, you can actually have the, sorry, you can actually have the lower parts of the brain herniate through the foramen magnum. And that is really, really bad and can cause severe respiratory depression and death really quickly. So we want to avoid that if possible. Is there a skull fracture and associated subcutaneous swelling? It might be a bit hard to see, but there actually appears to be a fracture about here. And as you can see, all this tissue is swollen. So there's subcutaneous swelling as well. Now, this is quite typical of an extradural or epidural hemorrhage. And most epidural hemorrhages occur over the temporal regions because that's where the pitris, or over the pitris bone, which is where you have an abundant blood supply. And they're most commonly associated with trauma. Now let's look at this one. What is the shape of the bleeding? And I want you to compare it to our previously seen one. So as you can see, again, this is where the bleed is. But instead of it being kind of oval shaped and well demarcated, this appears to be a bit more concave, right? And it appears to be extending way further than the earlier one. So again, going back to our first 5 questions for CTs, it's a bit more diffuse. It's crescent-like and all the way from the anterior to the posterior compartment. So it's way more, it's spread a bit more than the earlier one. Is the blood acute or chronic? Well, it seems more white than dark, which means it's probably an active bleed, but it's not as consistent as the earlier ones, right? If we have a look, this is nice and the density of it seems pretty consistent. With this, on the other hand, we have a few blotchy spots here and there. Again, I know this is not very technical, but it helps you to understand, I guess, how long the blood's been there. So if you're seeing darker spots, that makes me think, well, it's been there a bit longer than the previous one. Does the blood enter the sulci? No, it doesn't, because we can still see the sulci relatively well, and they're not filled with blood. And is there a midline shift? There is a very clear midline shift. As you can see, the ventricle is pushed almost completely to the other side. And is there a skull fracture or any subcutaneous swelling? Well, I can't really see much. Again, I'm not a radiologist. And this is a subdural hemorrhage. Now, if we go back to our first principles, a subdural hemorrhage would be obviously a hemorrhage that bleeds below the dura, below the dura mater. The reason we get subdural hemorrhages is a bit different to the reason why we get epidural hemorrhages. With an epidural hemorrhage, you typically have bleeding that is arterial in nature. That is because you hit the side of the head, typically, and then the artery profusely bleeds through. Versus subdural hemorrhage, and you would know that the space, or if you don't, well, I'm telling you now that within the subdural space, there's something called bridging veins, which carry the arterial blood to the venous circulation, right? Typical artery vein, and you have these bridging veins in the subcutaneous space. And when these bridging veins burst, that is when you end up with a subdural hemorrhage. Now, why do these bridging veins burst? If you think about it, you have, might be a bit hard to visualize, but if you have kind of your brain, and above that you have your skull and all your layers of your mater, you have these hundreds of these bridging veins that are running perpendicular to the brain, right? And usually the brain and the skull swivel a bit against each other. And as you can imagine, these tiny threads holding the two in between would also kind of move to each side. Now, usually this is not a problem, but over time, what happens in old people as their brain gradually atrophies and shrinks while their skull doesn't, that applies more and more pressure or tension on these bridging veins. Because of this, now these bridging veins are now nice and taut, which is why even slighter accelerations, decelerations, or sudden jerky movements can lead to a break in them, and then you have a subdural hematoma. Now, if we look at this picture, we can see something that's very, very similar in shape, right? But a bit different in color. So again, as the name suggests, it's a crescenteric hypodensity that is extending from the anterior to the posterior compartment, but it is much darker than its corresponding parenchymal tissue. This means that the blood is more chronic and has been there for longer. Now, this is typical of subdural hemorrhages because, as you can imagine, veins don't bleed as quickly as arteries, which is why chronic subdural hematomas are quite common. And as you can see, there's also a significant midline shift. Now, this is hard to explain in terms of the technicalities, so I will break it down to very simple questions. This looks like Patrick the Starfish, and that is all I ever think of when I see this picture. And all this screams to me is that this is a subarachnoid, and that is not good. As you can see, it's consistent throughout. Like, there are no asymmetries. This is because the blood is filling into the subarachnoid matter, which spreads relatively extensively and widely. So it's not isolated to one hemisphere. That's a subarachnoid hemorrhage, and it's probably the worst one of the three to have. And here's a good differentiating table between a subdural hematoma and an epidural hematoma. I like to think of it as a blue banana and a red lemon, although that probably doesn't help. So it's a crescent shaped, and blue meaning venous blood versus your epidural hematoma, that's going to be red, a red lemon, meaning it's a arterial bleed, and it's going to be more lemon-like versus the subdural that is more crescent-like. And epi, you think pie, lemon. I know it's a bit of a stretch, but sub banana. Hope that helps. So let's go through a few buzzwords. So patient presenting with a sudden onset, worst headache of their life with vomiting and meningism is going to be a subarachnoid hemorrhage. Again, remember, meningism doesn't exclusively mean meningitis. A unilateral throbbing headache with aura, vomiting, and photophobia, we discussed this earlier, is going to be typically a migraine. A headache with jaw claudication and pain while brushing their hair is going to be GCA, giant cell arteritis, or temporal arteritis, because the temporal artery is one of the most commonly affected ones. In addition to the temporal artery, it can also affect the ophthalmic artery, which is why vision loss is a really, really scary complication of GCA, which we always consider and try to look for. Pain that's worse when coughing, sneezing, confusion, seizures, any focal neurology, papilledema, as I mentioned earlier, are all signs of increased intracranial pressure. There is something in the head that's pushing it, and that's going to be a mass lesion, most typically. Lastly, and typically this is going to be in an obese young woman, you have increased pressure in the CSF, but you don't have any mass lesions that you can see. And this is going to be something called benign intracranial hypertension. It is pain that's usually worse on leaning forward. It does slightly look like your typical raised ICP, but it's slightly different because there's no mass lesion involved. Oh, we had another one. A head injury with a chronic fluctuating consciousness is going to be your subdual hemorrhage. As I mentioned, subdual hemorrhages typically do present with a chronic fluctuating course versus epidurals that are more acute. And that's all we had on approaching headaches. I hope that was useful. As always, if you have any questions, please feel free to get in touch on my email or get in touch with me on Facebook. I'm always happy to answer any questions you may have. And as always, please look after yourself and look after your loved ones.